I happen to love procedures in Peds. I love them more when they're not in the toddler age group, just because that's a tough situation. But we're going to talk of ways to make that a more pleasant experience, and not just by wearing earplugs for yourself. We're going to actually make these kids a little more comfortable. We're going to just talk some brief tips about vascular access, some wound pearls, some wound care pearls, pain and sedation, and how to best set yourself up for success for that pediatric LP. Remember, what we really need to do is keep in mind the developmental stage of the kid that you're at. I happen to be at a place so lucky to have child life, and I watch them like a hawk because they're not always there. But when they are there, I'm like, ooh, what are you doing with this kid? What are you doing with this kid? And basically, if it's a baby, they pull out an iPad. If it's a toddler, they pull out an iPad. And if it's a school-age kid, there's an iPad. And if it's a teenager, there's a combination of iPad and stress ball, like that they get to squeeze. But the point being, iPads are, if you want to invest in one thing to make your pediatric ED a little more comfortable, get yourself an iPad with a few games, some YouTube, some Bluey and Elmo. You're going to have a whole lot of happy kids, or at least a lot of distracted kids. And I think just getting them away from the procedure itself, especially if it's a painful or uncomfortable procedure, like that is really, really huge. If you have child life, my gosh, don't forget about them. Like sometimes I'm like in the middle of a screaming kid, I'm like, why have I not called them? And sometimes it's almost like a bat signal, like a screaming child like sends a signal in the air and this purple shirted person comes running in. I'm like, oh my gosh, you heard the call for distress, and they come up and they show up and they do their wonderful things, and they make my life so much easier. But a lot of these you can employ yourself. Whenever you can, sometimes we do have to restrain the kids for the safety of them, but the safety of us, of course, and that's fine. But we try to make it into a cute, like, hey, we're going to be a burrito today. What's the filling? We add the cheese, and they kind of enjoy that little play, just to do that, especially, and then they realize that I'm coming at them with needles, and they're less amused by the game. But hopefully by then the P over set is kicked in, and they care a little less. Whenever possible, if you have an ouchless option, take it. So, if I have a kid who's got a little swollen elbow and I know they need to go to x-ray, I'm not totally sure that it's going to be an operative supracondylar fracture, I'm going to give them a little squirt of intranasal fentanyl before they go to radiology, because we know they're going to need to be manipulated. Like, give them that. It's easy. It's very minimal access. You squirt a little squirt in their nose. Whenever it's a cut, throw some, topical lidoepitetrakine. Let that sit there before, maybe you'll need to numb it up more with injectables, but maybe not. Like, I can't remember the last time that with a facial lac in a toddler age kid, that intranasal fent, some P over sed, and topical let hasn't got me through it. And it's like, wow, I didn't need to inject this kid at all with anything, and the iPad, and they tolerated it reasonably well. And just for your future pediatricians who are going to have to take out your sutures, do them a huge favor and use absorbable sutures. Fast absorbing gut, Vicryl, both of those are, Vicryl Rapide, I should say, are good options for short amount of time for sutures. But again, I feel like every time if it's like an eyebrow, I'm using something that's non-absorbable, I'm like, oh, I can already hear them cursing my name, like when they see these sutures a week later. But we try to do our best. All right, we kind of talked about those distraction techniques. Again, if you don't have the resources for iPads, the babies love music. So if someone's going to have a cell phone, just put songs on. For toddlers, coloring books are a wonderful way to distract them. The school-age kids, they do like their video games. If you can get them a video game on a phone. And the adolescents, they just kind of want to, a lot of the time in my experience, they just want to be kind of left alone, and they could stress, but let them text their friends, while you're doing something, if it's amenable to that at all. Use these topical agents. I would say that the ones I use most commonly for intact skin, you can use EMLA cream, which is a eutectic mixture of local anesthetics. It takes a while to take effect. It takes about an hour to really work. I prefer the Elemax just because it happens about in half the time. Put an occlusive dressing over, and if it's like for an LP, put it not just in the spot you're going to go. Put it a layer above and a layer below, because you never know. You might need to do this procedure a couple times. And this is, when it's for an LP, I do it myself, because oftentimes if I let someone who doesn't have a ton of experience, I find they put it like just above the cleft of the butt crack. And I'm like, that is not L3, L4, so put it there yourself. That way you don't have to wait another half hour when you have to put it in the right place. For IV starts, ethyl chloride or cooling spray is a really nice option if you got it. Some of the nurses do complain that it sort of makes it a little harder, like the vein constricts like a little bit, and it's harder for them to get. But if it's a toddler age kid or just a really skittish kid, I'll use a little vapor coolant. All right, oral pain meds are nice. They take a long time, but if it's gonna be a minute, like you have a abscess that needs to be I&D, sometimes I'll give them a dose of like acetaminophen, hydrocodone. I think they're best served probably with more local agents or topical agents. IV meds, I mean, for painful conditions, treat their pain, right? I think a lot of people are scared to give kids opiates, but if they have a painful condition, they need opiates. And if they just got in a car accident, their leg is broken, give them morphine. And it's nice and long acting. I'll start it at a dose of like 0.05 per kilo if they're completely opiate naive. But once they've proven themselves, give that to them and repeat the dose and check in on them. I think it's easy to be like, oh, I gave you morphine, I forgot about you. And then, an hour later, they're screaming in pain. Fentanyl's nice because it's short-acting, so I tend to use that in the acute trauma setting where I'm unsure about their neurostatus, and I kind of don't want to knock that out for hours on end. We'll use that. And hydromorphone, our hospital does not carry anymore, so people stopped asking for that drug that starts with D. I don't know if that's a trend in a lot of places, but it's a very effective pain medication. I like it because it's less emetogenic, right? So if you have, the morphine is just so emetogenic that if someone is having abdominal pain and vomiting, I want to use a different agent because I know they're going to just barf even more. Topical medications, I will tell you, that LET is the one I go to, and I love when it's in a gel. If there's like a superficial lac, we'll plop it on there. It doesn't matter where it is, except if it's near the eye. I don't love it because we don't want it dripping in there. But one handy tip is to put on a cotton ball instead of a gauze. The gauze tends to absorb the LET gel, whereas the cotton ball kind of keeps it on there and it just kind of sticks right on there. So I like that. They've actually done studies looking at multi-dose LET to see if it's better. It's not. So you put it on there, you leave it there for 30 minutes. What you'll notice is there's a ring of pallor around the area. And if there's that ring of pallor, despite how anxious the kid is as you come at them with a needle, they're numb. They're just probably really scared. And if that's happening, then you need more anxiolysis than you need pain medication. For anxiolysis, I love intranasal midazolam. It is a great medication. You could use 0.2 per kilo of that at max of 10 milligrams. If you want to go oral, sometimes I'll give an oral dose of PO versus midazolam. The reason being, it takes about 20 minutes to work, which is exactly about the amount of time it takes for that LET to work. So if I felt like a kid with a forehead lac, we'll put the LET on. I'll give the PO Versed at the same time. And when everything's ready, they're kind of a little mellowed out by the anxiolysis. The numbing has taken place. We can go to work and get them fixed up. A lot of times the LET, if it's a bigger cut, I'll put the LET on there, but if they're just not having enough anesthesia, I'll take some Lido with epi if it's not an N digit, and the key with that is just the smallest needle you can find. We have 30 gauge needles that are like just fine hairs, and a slow injection of a 30 gauge needle, sometimes if you've already put lead on there, sometimes the kids don't even realize what's happening. You just kind of talk them through it. Again, Bluey's in their face or Elmo's in their face, they're distracted, you're injected, you're happy, you could do your work without having the screaming happening. If it's a bigger deal, a more painful, more prolonged procedure or a delicate one like a lip or an eye, that's when I'm turning to ketamine because I really need them to be still so we could have that, that perfect repair. The IV opiates are great, and I think for generic pain, that's great. For procedural pain, I find myself, if it's going to be a very painful procedure, I find myself relying more on either the injectables with the local or just ketamine to totally dissociate them. Suture materials, again, your pediatricians will thank you. If it's a superficial cut that needs repair, use something absorbable. I will tell you that the fast absorbing gut on the face, which in theory we should be using 6.0, the smallest out there, I just can't do it. It just breaks every time. So I've accepted the fact that I'm still going to use fast-absorbing gut on the face. I'm just going to use a 5.0. And the difference between 5.0 and 6.0 is not so big that I think it's going to make a ginormous aesthetic result difference. So that's the way it's got to be. Chromic gut, I don't find myself using very often. Maybe nail bed repairs, tongue lacs, which are the worst things ever, oral mucosa if it's really, really gaping. But you know, in general, lacs inside the mouth, they do really well. Like, unless it's really, really gaping, you know, like the mouth is used to teeth grinding and chewing and tearing, and it heals up really, really quickly. So I don't find myself using that very often. If you find yourself not able to use the fast-absorbing gut because you don't like the way it feels or it breaks too often, Vicryl Rapide is something I've seen our plastic surgeons use, and I think that's a really nice option. All these absorbables, if you put like an ointment-based antibiotic on there, it does speed the degradation of the suture material. So at least early on in the course, I tell them to not do that, to just leave it alone for 24 hours. After that, just kind of soap and water. Maybe later in the course, if it's approaching that 5 to 7 days when I know the sutures are going to come out, I'm like, yeah, go ahead and put that on. Let's speed that up. That actually might be a good thing. Proline, you know, for regular repairs, I'm just using regular nylon, right? But Proline is that blue suture, and I really like the blue suture for like eyebrow repairs or something that's, you know, as I get older and need my glasses to do these repairs, I'm like, the last thing I need to do is distinguish between suture and eyebrow hair, and it hurts to get an eyebrow plucked, as many people could probably attest. So I love using the Proline around those hairy spots. If you're trying to figure out what size, there's general trends: smaller on the face as you go down to bigger, right? 6.0 to here. If it's, you know, chest and trunk, probably a 4.0. If it's a little kid, you're going to maybe go smaller. But basically, cephalic to caudal, you're going to use smaller to bigger. As you go from central to peripheral, you're going to use smaller to bigger as well. And the same goes with trends for how long you're leaving those in, right? So face is only getting 5 to 7. If it's axial trunk, you know, 7 to 10 is fine. If it's a extremity, 10 to 14 days. If it's especially a bendy spot or a foot that's going to get a lot of trauma, more like 14 days, just to keep that in there. Tetanus vaccination updating, I find to be one of the, I think it seems to be like this intimidating thing, but it's actually not that hard. Tetanus only lives in a few places that we encounter with these cuts. It's in soil, it's in rusty nails, it's in bites. I think bites is sort of underappreciated where tetanus might live. But if you look at this chart of when you need to boost, it talks about whether you've had 3 doses of tetanus vaccine or less than 3 doses. If you're over 6 months and you're vaccinated, you're in that bottom category of you have received, because you get it at 2 months, 4 months, 6 months, right? So there's not a lot of babies that come in with lacs, right? So most of these kids, if they're vaccinated, are going to be falling in that bottom category. And if it's a bite, if it's been more than 5 years, you're going to boost them. If it's not a bite or soil or rusty nail, you're going to wait 10 years. So a lot of the kids, just because of the nature of the frequency of getting their tetanus vaccines, aren't going to need boosting. The one category that I will point out is there's actually 2 medications you might need to use in tetanus exposure. There's the booster vaccine, but there's also the immune globulin, right? So if you have a kid, and you'll notice you only see it once on this chart, if it's a dirty wound and they have less than 3 tetanus vaccinations, you need to give that immune globulin. So if you have this is unfortunately much more common than it used to be, but vaccine refusers, they get super sad when you're like, hey, not only do I need to give you a vaccine, but I also need to give you some other immune globulin because you didn't vaccinate your child. But that's that one unique situation that sometimes happens that you guys should be aware of. What if they refuse? You tell them the risks and the benefits, and you sort of have to deal within the realms. You can't assault someone's child, but at the same time you could give them the risks and benefits, and that's the best you could do, and tell them what the symptoms of it are. Sorry, sometimes. It depends. It really is very case by case. Sometimes if I sit down and take the time to talk to them, I can actually convince them that this is going to benefit your child. Or if you were against getting the vaccine because you didn't think it was likely they would get tetanus, I could tell them, hey, now you're in actually a high risk situation where we know this bacteria lives, and you show them a few pictures online of what tetanus looks like. It's a fairly compelling argument. Yeah. Vascular access is one of the things when the nurses are having trouble, it kind of cracks me up when they come to me. I'm like, really? My nurse of 30 years can't get the line in. You want me who does an IV like once every 6 years? Okay, sure. I'll be glad to take a look. And then I find my newest resident who is excellent at ultrasound and peripheral guided ultrasound IVs, and I have them put one in here if they can get it. Or better yet, we call the NICU or the PICU, where these people can put IVs in rocks and somehow blood appears, and I'm like, oh, okay, great, good job. But use your resources around you. Find the most experienced nurse. It's these kids with the higher BMIs, the really tiny babies, the dehydrated ones, the sick ones. You guys know. Even if you get a flashback, the vein collapses. If they're really, really sick, don't worry about the IV access. You've got other tools that you can go to that we're going to talk about. If it's a tiny, tiny baby within the first 7 to 10 days of life and they're real, real sick, umbilical vein catheterization is a shockingly easy procedure. I think it's intimidating because, at least those of you who didn't do Peds residency, like in Peds residency, you go through the NICU so many times that you actually get used to it, and you realize, imagine if your patient's necklines could be like you could cut their head off and thread it directly into their jugular. It's like, well, that's an easy procedure. This is essentially what you get to do, right? You basically, you tie a little string around the bottom so you don't start to bleed, and then you take some forceps, you cut across, and you're going to see 2 small vessels and 1 bigger vessel. It almost looks like a little face. And basically, you can dilate the mouth of that face, because that's the vein. It tends to be a thin-walled, a little floppier. You just dilate it, and you literally pass a 3.5 French catheter until you see blood come, and then go another centimeter. As soon as you could withdraw blood from there, you got yourself a central line. Like, what could be easier on a baby, right? Like, everything else is harder to get on a baby. And then you secure it by putting this little goalpost type thing to make sure that it doesn't move. And, if you have a NICU, they are very, very glad and very experienced to do this if you're, out of practice with it. But it really is not a technically difficult procedure. You do have to make sure that it's a viable cord, that you're actually going to see a blood vessel. So if it's like, 10 days and it looks black and necrotic, you probably lost out on that opportunity. But literally, if it's a kid in the first week of life, there's a good chance that you could, have enough of that cord to be alive to be able to use it. Intraosseous lines. Remember that kid I was talking about who you tried to get IVs and everyone tried, they couldn't do it and they were sick? Get an IO line. It is the only procedure easier than the UV line is IO access. It is like with the drill and the easy IO, it is really, really easy. Don't wait if they're really sick. So if they've tried 2 times, it's been over a minute, and they're very, very sick, go for it. And essentially, there's a few places you can go. The most common one that I like is a couple finger breaths just below the medial aspect of your proximal tibia. And if you feel it on yourselves, which hopefully you will, you'll feel that like flat surface there. And it's not directly like this, it's sort of at an angle, and you want to go perpendicular to that angle. If you put it there and it stops working or it infiltrates, you can't use it, don't put one in the same bone. So, you could use medial mal, but if you've already tried one here and it didn't work, don't go medial mal in the same bone, because that bone is gone. But what you can do is the other side, right? So you go to the other side. If that doesn't work, you could use anterior femur. I've heard people doing proximal humerus. I'm not experienced in that, but it can be done. In terms of what needle to use, the kit makes it super easy. For most kids, it's going to be that little pink one, right? This goes up to 39 kilos. That's probably going to get you to a 10-year-old, right? So after that, you can use the blue one if they're older than 40 kilos. If they're extremely high BMI, sometimes you'll have to use the yellow one. But you basically just clean the skin, and you're going to go perpendicular to the site, and you literally like drill it in, and you'll feel like a little pop. It kind of gets stiff. You undo it. You can withdraw blood. You can send labs from it. You can give any medication you give IV. You can give through an IO. And hopefully, if you've hydrated them a bit through that IO, you'll eventually get the vessels to be plump enough that you could actually get an IV on them. There's also the non-drill version, which is the hand-twisty one, which is pre-easy IO, what everyone used to use. I like these for the smallest babies. So if it's like a preemie who's teeny tiny, I find the drill, just even the pink one often goes right through them. And so for those kids, I'm actually, and it's really a feel thing. So it's the same anatomy, but you're just being real gentle and just waiting for a little bit of a give. Once you get that little give, and it should remain rigid in there. It shouldn't flop over. It should stay stiff, and use it just like you would use any other IO line. If they're awake, Getting it placed is kind of painful. Infusing is extremely painful. So you actually want to give them lidocaine, 0.5 per kilo, through the IO line if they're an awake patient. Because you hear someone howl when you place an IO if they're awake, but you really hear them scream once you start to infuse anything through there, and it's not that much fun. Once it's running, and if you're using it to infuse anything, you really have to feel so if you put it here, you want to feel the calf behind to make sure it's not extravasating behind, because that's an easy miss, because it's on the bed, and that could be a big problem. And basically, if that happens, you stop using that one and you find other access. These don't stay forever. These are very much an ED thing. Use it for 8 hours. Sometimes they go up to the PICU in this. Really a max of 24 hours. By that time, we're going to talk about this hypodermal crisis, but I'm going to tell you that this is a nice option when you're not in crisis mode. So those of you with dehydrated cats or dogs have probably heard of this, where they put a little injection in the nape of the neck of basically it's hyaluronidase. It breaks down the soft tissue, and then you basically just stick a 25 gauge needle, and you can rehydrate that way. But it's got to be not a kid who's shocky. If they're shocky, do an IO. You could do the same thing with the kid that you do with the cat. Basically, right between the scapula, you pinch there, you put this recombinant hyaluronidase, 150 units. You wait a bit, and that basically allows the fluid that you're going to give to go into the subcutaneous tissue, into the veins, and hopefully that will get you to a state where you have plump enough veins that you can actually get peripheral access like you would otherwise do. Underappreciated, I think, is NG tube rehydration. It totally works. It's uncomfortable. It's not fun. If you can get an IV, it's probably less traumatic for a patient, actually, but it works. Even if they're actively vomiting, you could still put that NG down and try it. If it's a bunch of diarrhea coming out, for sure put that NG in if you can't get access. Hydrate them. The body will absorb it, and hopefully, again, you'll get to a place with more plump veins. Sedation for procedures. I think it's going to be a very painful, very distressed child, or I need them to be still because it's a difficult lip repair, something near the eye, or if it's an LP that I need them to be still for, I'm going to use ketamine. It's such a great drug for kids. I will say that the doses I'm going to use, I'm going to start at 1 to 2 per kilo, and people talk about whether with head injuries you should use it. I think the literature has pretty much borne out it is safe to use that. There was even some worry about intraocular pressure being raised. I don't even think the literature has proven that we can't use it for that one indication, the eye. I'm still not totally sold that it should be our first choice, but for head injury, for LPs, for complex lac repairs, for INDs that a little kid can't tolerate, ketamine is lovely, and it works. I've used propofol before. I find it's wonderful if you have a very quick procedure that needs to be done. It doesn't have a ton of analgesia, so MRIs it's wonderful for if you can have someone sitting there and titrating it at the bedside. But I think I prefer for the painless procedures to do something like midazolam, either an intranasal 0.2 per kilo or a PO 0.3 to 0.5 per kilo, with the max dosing of the intranasal being 10 milligrams and the max dose of PO Versed being 20 milligrams, which sounds like a lot, right? 20 milligrams of Versed, but so much of it is first pass metabolized by the liver that I don't even worry about it. How many of you have nitrous oxide access for procedures? I see a couple of hands. We had it for a while. I found it interesting. I don't know if I enjoyed every moment of it. It can be used for anxiolysis mainly. It doesn't have a lot of analgesia to it. There's a lot of vomiting afterwards, is what I discovered. So I'm not a huge fan. I no longer have access to, but it's absolutely an option if you have that at your institution. Local. I think lidocaine is pretty much the gold standard. The one thing I would say is, remember, you do have maximums. So if it's lido without epi, 4 milligrams per kilo. If it's with epi, 7 milligrams per kilo is sort of the maximum, just so you don't get that lidocaine toxicity. If you need really prolonged anesthesia, just remember things like bupivacaine last a lot longer. The lido only lasts 30 to 60 minutes, which is, if for a quick lac repair, that's great. But if it's going to be something more complicated, maybe the bupivacaine is a better option, though the bupivacaine takes 10 to 15 minutes to start acting. And even the lido takes 5 minutes. I see a lot of my residents go in there lido, so. I'm like, whoa. Go get a drink or something and come back in 5 minutes once the lido has had a chance to work. Nerve blocks are, I've come to love them over time, especially vermilion border lip lacs, man, or something that you really need to see the anatomy and not get distorted by local. These are wonderful. They're actually really, really so much easier than you would ever think. This is the only one of the nerve blocks that actually involves going through intact skin, the supraorbital nerve block. You could see on the kid, the blue area is where the area that you're going to knock out, that's going to have anesthesia. And basically, if it's a really complicated or multiple lacs that you need to do, you're going to end up using a lot of injectable lidocaine, and you could forego all that by just doing a quick supraorbital nerve block. You just take 1 to 3 mLs of local, just at the level of the eyebrow, and you make sure you're not in the blood vessel, inject there, give it a few minutes, and touch the kid. And they'll draw the outline of where they're numb, and you know where you can safely work there. I like these other nerve blocks because these are totally painless. What I do before I inject is I take some viscous lido on either a gauze or a cotton ball, and I stuff it in that vestibule between their tooth and their mucosa and leave it there for like 20 minutes. That totally numbs them up. And then you get a long 25 gauge needle. In this case, for the infraorbital, you basically want to go right in the midline of the eye over the canine, and as you're injecting, you're feeling with the tip of your finger here for the tip of the needle, which should be just underneath. Inject a few cc's, give it 10 minutes, and man, you have got great anesthesia for this entire area that's blue on there. And we did a full thickness lip lac the other day. This girl, she didn't bat an eye throughout, even the nerve block. Just sat there and was like, okay, cool. The same thing can be doing on the lower half with these mental nerve block. It's also in the midline just below the canine. Again, viscous lido in the mucosa before you inject with that long 25 gauge needle. Palpate that mental foramen there and just insert the needle and feel there for the tip and just inject, and bam, you've got that whole part of your chin and the lip taken care of. This inferior alveolar nerve block is a really nice one too. You basically go to the back of the, between the molars there, and you're going to knock out the anterior two-thirds of the tongue as well as this whole front of the mouth. And if you need to do anything dentally, it knocks out the teeth as well. So it's a really, really nice one, and it's easy. You're just going to put your finger in their mouth. You're going to feel that coronary process, and you're just going to inject right where this slide shows to inject. And 1 to 2 mLs. A few minutes later, you've got great anesthesia. For complicated ear lacs, I find these, I'll do auricular nerve blocks. I'm usually doing it in conjunction with some ketamine sedation because these just, I think they're hard to do on the awake child, but what I know is that once I'm done fixing them, that auricular nerve block will stay and that they will still be numb and be comfortable when they wake up. And essentially you want to go from the top and just make like a little crisscross there, and on the bottom, another crisscross there, and you've knocked out all the nerves around the ear, and you could operate on that ear to your heart's delight. All right, pediatric LPs. I know people who don't do this a lot get very anxious about it. I find the infant LPs are so much easier than the very, very large rule-out pseudotumor ones where I'm like taking a javelin and like, okay, I hope this goes where I want it to go, and you're just kind of hoping for the best. You could feel everything in these babies. There's so little tissue to go through. You could feel out their bony landmarks. I personally prefer lateral to cube. I have also, if my resident has tried and it's been a couple attempts, I will and if I tried and still can't get it, I will sit them up just because I think the biggest problem is just the alignment of the child when they're lying laterally like this. If whoever's holding slightly turns them one way or the other, sometimes you'll go too high or too, like if they're turned like this, you're going to kind of miss them this way or this way. And so if they're sitting up like this, I'm feeling all their spinous process above, and I could see their little butt crack below. I actually tear a hole in the sheet so I could see their butt crack because I know that's midline. And I basically put my thumb on the process above, and if they're sitting up, I'm going to lean them forward a little bit and just go literally straight in. If they're lying down, I'm going to still put my thumb on the spinous process toward their head, right above where I'm going to go, and I'm basically going to go just slightly 10 degrees cephalad so I'm not going straight in, I'm going slightly up because the vertebral processes come off at an angle, and I'm going to insert the needle slightly, take out the stylet once I'm initially through, right? Because you can do that safely. You won't leave like a plug of tissue or anything like that. And you basically slowly advance with the stylet out. I find this very helpful. This is the Cincinnati method for my novice or infrequent LPers because they're so used to doing adults, they're like, and I'm like, that's a bit far. But if you just go slow and you just kind of, as you go, you wait, and then you can actually see the fluid as it comes out. The one thing for the holders magnetometers that I will say, I find sometimes they crunch these kids up so much. And really, it's not about the neck flexion. It's really about the hip flexion. So you got to flex that hip. That's going to open up the space. The other one is if you're sitting them up, put a few blankets and let their butt hang off the edge of that blanket, and that will kind of just force them to naturally curve a little bit more and open up the space a little bit more, hopefully setting you up for a little more success there. Really quickly, we'll talk about foreign body removals. Ears, nose, GI. In the ear, I will say this, if it's a non-organic material, like a bead or something like that, you can absolutely try to irrigate that, and I think that's really nice. If there's known TM perforation, don't do that because you don't want to squirt that in there. If it's a live object or a organic plant object, do not put a bunch of water in there. It's going to make it swell and you're going to be very unhappy. If it's a live object like a bug, first of all, everyone's going to scream, and even you might scream because you're going to put your otoscope head and it's going to be magnified and it's like Godzilla's coming at you. But you need to kill this thing first. And there's a very interesting study out of Germany which looked at what will kill this bug the quickest, right? People put lidocaine, all kinds of things. What they found was it was microscope slide oil that actually killed them. And so they've sort of extrapolated this. You can use mineral oil, and that actually has the fastest kill rate of the bug. So use whatever you want. I think lidocaine is fine too, but if you want to do it fast, mineral oil apparently is the way to go. For those, if you can do it, like just getting a little alligator forceps and pulling it out, hopefully it comes out whole. The worst is when it's like, oh, a leg, oh, an eyeball, a shell, okay, gross, and everyone's like, and the kid's freaking out. So hopefully you can get it out wholesale at once. If it's a magnetic object, magnets are like a really great way to get out a magnetic object. You just pull it right out. People talk about using this like Dermabond or the cyanoacrylate glue on the end of a stick. I've tried it. You got to wait till it kind of gets real tacky. One tip if you're going to do that is put the largest speculum in the canal itself, because the last thing you want is like, boop, oh, I just stuck this to their external ear canal, and now they're bleeding, and now there's an ENT out there who hates me even more, more than the fact that I'm referring this kid to them to go be seen the next day. Unless it's a battery, in my mind, it's not really an emergency, right? The batteries need to come out, but a bead, if I can't get it, I'm going to make my college try. I'm going to do that, but it's okay. They can go home with a bead in their ear. Nothing bad's going to happen, so they can go see ENT, like as an outpatient, non-emergently. Or if it's daytime and my ENT's feeling nice, hey, go over to the clinic, and they just have better tools to do this stuff with. So that's my spiel on the ear foreign bodies. Nasal foreign bodies are actually my favorite because I find these extremely, extremely satisfying and fairly easy to remove, even when they're jammed way back in there. There's many ways to do it. There's the parental kiss, where they basically occlude one side. You have the parent blow into the child's mouth, and snot and foreign body flies out. If you don't like the parent because they've been rude to you, do not give them a gown. If you do like them, provide them with a gown because it gets super messy. You could even use an ambu bag and do the same thing. My tried and true way is honestly a simple like 5 French Foley, or they have a cat's extractor, which is like a stiffer version of this. And it's basically a balloon on the end of a catheter, and you're basically going medially along the nasal septal wall, bypassing the obstruction, blowing up the balloon, and just pulling it back. And it universally works. I will tell you, I've probably done 100 of these. The 2 times it's failed have both been the same situation. They've been batteries that have coagulation necrosed into the nasal wall. So if you see a foreign body and you can't get it out using that method, take an x-ray. Make sure there's not a battery in there. If you could see it, and it's like a little ring, and it's easy to grab, and it's not slippery, and it's like right at the edge. You could grab it with an alligator forceps, but the satisfaction of using the cat's extractor, the Foley, it's next to nursemaid's good. So, all right. Last thing is just GI foreign bodies. They happen, right? I worry if it's sharp or if it's particularly big. So if it's more than 5 centimeters long or 2 centimeters wide, it's a little bit more high risk. The biggest risk is, of course, button batteries or multiple magnets or magnet with metal object, right? Because that can cause, across the intestine, cause some necrosis. We had a case of this kid, he just a month ago, came in with vomiting, got admitted for dehydration. No one took an x-ray because no one got the history that this kid ingested magnets because he didn't tell anybody. A few days later, he starts to get real sick. His belly gets distended. He gets peritonitic. They shoot an x-ray. There's 6 magnets, and that had perfed his intestine. He ends up in the OR and getting very sick in the ICU. So just something to think about, that if you see multiple magnets, take it seriously. If you know you have someone just ingested a battery, honey, before they even get to the ER, if you have any say in it, if the paramedics are calling you, be like, give this kid honey. If you have honey accessible, you're picking the kid up at home, tell them to take some honey before they come to see you. That'll buy you some time so they don't get such esophageal injury, which can happen really, really rapidly. And that is the end.